Welcome everyone to this week's speaker series. On behalf of CanCOVID, I am delighted to welcome Dr. Deborah Money for her talk, What the Research Says on Pregnancy and COVID-19. Before we get started, I just want to let everybody know that the talk will be 20 minutes. During that time, you can take your questions and type them into the chat box. At the end of the 20 minutes, we will have 10 minutes for questions. I will read those questions out loud and Dr. Money will answer the queries. If you have a question that you'd like to submit to Dr. Money directly, you are more than welcome to turn on your camera and your microphone and join the conversation that way. So without further ado, here is Dr. Deborah Money.
Thank you very much, and I'm pleased to be here today. I'm just going to try and share my screen. So very happy to talk about COVID-19 and pregnancy, a topic near and dear to my heart, and I will give the full acknowledgements at the end of my talk, but this, the data that we've been able to accumulate here in Canada is on the backs of a huge number of individuals who've been really collaborative across this country trying to understand this issue. To advance my slides. Here we go. I do want to acknowledge that I work, live, and play on the unceded traditional and ancestral territories of the Coast Salish people, the Musqueam, Squamish, and Tsleil-Waututh nations. And so I'm going to have a couple of slides just talking about the epidemiology of COVID-19 and pregnancy, and then review a bit of the global data, not all of it, but just a couple of the big highlights. And what we're calling the Canadian bundled data so far, which is preliminary information from CanCOVID Preg, which is our Canadian study on surveillance of pregnancies affected by COVID-19. And I'll just touch on this seroprevalence study just to give you a taste of what's coming up. I do have several conflicts that I want to mention. Many of them are not relevant to this talk, but we are very generously funded for this work by the CIHR, the Public Health Agency of Canada, and the BC Women's Hospital Foundation. So first off, just to understand prevalence of COVID in pregnancy, I guess my message here is we don't really fully understand it because we don't track it at a population level all over the world in the same way. But we have been looking to this group, which is a WHO collaborating center at the University of Birmingham, that have been doing what they call a living systematic review, which is trying to cull through the literature and understand what the literature is telling us, because it is a very strange time for information in COVID, certainly in the perinatal literature, where we were getting multiple repetitive reports that were containing the same data and overlapping with each other. So it really is quite a chore to weed out and actually get true individual distinct data. So this data suggests that the prevalence of COVID in pregnancy is there's about 10% of pregnant women with confirmed COVID-19 globally. And again, this is massive ranges in the studies depending on the local epidemiology, but in the meta-analysis of 24 studies, there was 4% of asymptomatic women and 41% of symptomatic women who were actually COVID positive. So it looks like, based on this data, that the acquisition of COVID-19 doesn't appear to be higher than in non-pregnant persons in the population based on the spread in their local area. So this is the story as of variably a week ago or so, a couple weeks ago in Canada. And we have seen perhaps surprising uptick in the number of pregnant women who have been affected by COVID-19, by SARS-CoV-2. And what we're seeing is essentially a reflection of the underlying increase in Canada in the provinces that are being hardest hit. And Manitoba, even since this slide was put together, is going up and up. So overall, we have just over 1,500 cases of COVID-19 in pregnancy, Still a low proportion of the total population, but you can see that this is a significant number of pregnant women being affected by this pandemic. So what I'd like to do now is really drill down to try and understand what we know, a fair bit we don't know, with regards to outcomes for COVID in pregnancy, COVID-19. So I'll give a little bit of the living systematic review data, tiny bit of the recent MMWR data from the CDC Atlanta, and then some very, very preliminary information from a global perspective meta-analysis, and even more preliminary information from Canada. So what we have here is the living systematic review data that suggests that although in the very early reports from China and so on, where we were seeing very high rates of prematurity, in the more recent literature, looks like premature births are higher, about 2 to 3 times, in this case, threefold higher than baseline. And cesarean births are higher. The trouble with stillbirths, neonatal deaths, and admissions to NICU is the numbers are so small that it's not really appropriate to draw conclusions, but there's a general concern about an increase in stillbirths in persons with COVID-19, pregnant women. Now, maternal mortality, fortunately, is something we don't talk an awful lot about in Canada, but is an issue in many parts of the world in general. But here, what we see is that in low and middle income countries, mortality amongst pregnant women with COVID-19 is actually quite high, but in high income countries, not the same. So there were 73 cases of maternal mortality in over 11,000 cases in 26 studies. Now, as time goes by and the numbers get bigger, we may start to see some issues in high income countries, but all this data has to be taken in the context of the underpinning medical and social framework of the country. And then looking at mortality among pregnant women compared to non-pregnant women of reproductive age, what we see is really not a significant difference between the two groups. And in comparing pregnant women with COVID to pregnant women without COVID, there is an increased risk of mortality, but the numbers are very small here. So I don't think we can jump to conclusions too much. So then just to move on to what is this very interesting project, at least in my opinion, which is this global sequential prospective meta-analysis that has been set up with this very large group of international collaborators that is being coordinated out of George Washington University in the United States, and the lead is Emily Smith there. And what she has been able to do is garner interest and collaboration from many, many groups across the world. And we are one of them that have been working with them initially on the underpinning of doing this, which is actually having some standardization of data elements in all of our different studies and surveillance projects, so that in fact we can compare apples to apples. It's tough enough to compare maternity outcomes between Canada and Mexico and Kenya without at least understanding that the kind of variables we're assessing are similar, if not the same. So we worked very hard with them on data harmonization. So at this point, I should just mention that this is coordinated with the American College, FIGO, and ICHD and WHO. So to date, everybody is working very hard, but this is all taking longer than we would all like. And so there's only been a handful of to participate and to date. And there's two ways people are participating. They're either sending data to the data coordinating center, or the codes for analysis are being sent. And our approach at the moment, because it's, I think, going to prove too difficult to send data, is that we've received the analysis codes, and our biostatistician has been working with them on how to do that. So we're planning to participate formally, but we have not fully joined yet. So this is data from a very, very preliminary poll from 3 studies that is looking at the sort of big picture outcomes: pregnancy-related death, obviously a major outcome, preterm birth, and so on. So in these studies, which include both low and middle income countries and high income countries, there was a significant rate of maternal mortality. Preterm birth rate is again this increased but not dramatically increased rate of 10.3%. Low birth weight, not dramatically increased. And stillbirth, again, I think we have to be cautious with interpreting that stuff. So this has been a very talked about publication. There's been a series of them. This is the most recent one. Sorry, I've kind of stretched it to try and see it on the screen, but this is data from the CDC. And in the MMWR, obviously. And this is just a screenshot of sort of the core message, which has got a fair bit of press, which is that, that ICU admission for pregnant women compared to non-pregnant women is substantially increased. Threefold higher, in fact. Now, what's important, of course, is the absolute numbers are low, thank goodness, but it's still a significant increase. And so that has created some, obviously, attention and concern. So just a commentary on this, and they also talk about other adverse outcomes. First off, they report rates per thousand. So just be careful when you look at the number. It's like 10%. No, it's 1%. There is low absolute risk, as I said. Pregnant women were at increased risk for adverse outcomes measured by ICU admission, need for ventilation, extracorporeal membrane oxygenation, and death, although the death was very minimally statistically significant. They did, however, limit this to symptomatic women, and it's a reporting system. So they actually have to actively report to the CDC, which is obviously a workload issue that only some hospitals can, and may lead to a bias of reporting on more adverse outcomes than the benign outcomes. The population is US, Southern US mostly, and different than ours. And pregnancy status was missing in, this is a big database that they're pulling pregnancy data out, and pregnancy status was missing on over half the cases. So there is potential bias there. So now if I can move on to talk about Canada. And what we've been able to do, which I think is really a testament to collaboration across the country, is we've been able to pull together leads and groups in every province and territory for the purposes of providing Canadian data on COVID-19 and pregnancy. And we actually came up with the CanCOVID PREG prior to understanding and COVID. Actually, a copycat there, but it's actually turned out to be kind of maybe useful. So we want to look at the burden of disease, look at maternity outcomes, look at fetal and infant outcomes, and this will, of course, help inform how we approach management planning, and also sharing our information with the international collaborations. It is a surveillance type of project for the most part, and we're looking at any cases and pulling data on any cases of actual SARS-CoV-2 NAP positive in pregnancy. So we identify in most provinces through public health a case that is pregnant, and then we collect the data retrospectively postpartum. And with the exception of Ontario, where we link in with Born Ontario, we have a standardized REDCap database with data harmonization. We have made both great progress and somewhat slow progress in that we have almost every province and territory in play, but active data collection has only been really uploaded for BC, Alberta, and Ontario, and Manitoba and Quebec are coming online shortly, and it's individual agreements with each province and territory that is fairly slow moving. We did start with coordinating our data elements so that they could be standardized, and we do work with other networks across the country. So this is just a little bit of the data from a poll that was done with the data ending September 30th in the 3 provinces. And this data will be made public soon, but isn't yet. So couple of things to start with. Gestational age at diagnosis, contrary to the MMWR publication, is diverse across the gestational ages. So I think that reflects probably a bias in reporting to the CDC, where we are seeing basically women acquire this infection at all gestational ages, more dependent on circumstances, not pregnancy. Maternal age is fairly reflective of maternal age in the country. And I think our numbers are quite small to get the subset of comorbidities, but it is notable that we had a fair number of women who are considered obese and with diabetes, which of course are comorbidities for adverse outcomes for COVID-19. Mode of acquisition is not a perfect variable, but community and healthcare worker is the most common. Now, this was something that many people were interested in. Would the presentation of COVID-19 be different in pregnant women? And we're not seeing dramatic differences. Cough and fever are the most predominant. It's very hard to know how to interpret anorexia, nausea, vomiting, as these are such common symptoms in pregnancy. Even fatigue, malaise can be as well, but certainly shortness of breath is fairly common, and again, a little bit hard to interpret with the sort of physiologic shortness of breath associated with pregnancy. But these are the reported symptoms. What we did want to focus in on, because of the attention in the international literature, was were we seeing much in the way of adverse outcomes in these young, otherwise for the most part healthy women. We are seeing so far in this data 11% hospitalized, 2.3% ICU admissions, and some individuals requiring mechanical ventilation. Now, what we were able to do in British Columbia, which we will be able to do across the provinces, we just haven't got that data yet, is have a look at pregnant versus non-pregnant, which gives you a point of reference for that other multi-province data, which is that non-pregnant women of the same age in Canada who acquire SARS-CoV-2 have much lower rates of hospitalization, of ICU admission, and we haven't been able to pull the mechanical ventilation data, which suggests it's probably 0. So I think it does give us pause that we are seeing the kind of rates that we are in ICU admission and hospitalization, even though our numbers are small, suggesting that perhaps pregnant women are doing worse with COVID-19, a little bit more akin to pandemic H1N1. So delivery outcomes in our data, we are seeing a two-fold delivery, about 15%, and it's about 8% for the most part across the country. That has not been broken down yet in terms of the reason for prematurity. Is it that the mom's sick and it's a medically indicated preterm birth, or is she actually going into preterm labor, for example? And then in terms of infant outcomes, we are seeing, the majority of infants are doing well. They are mostly being breastfed, although a fair number have gone with substitute formula, and that's presumably related to anxiety over transmission, but we don't have that data yet. NICU admissions are comparable to the prematurity rates, so probably mostly related to prematurity. And we are having difficulty with getting the nasopharyngeal swabs for SARS-CoV-2 being done in the neonates. So we have limited information on that, but it's important to know that there have been some positive infants. So that's kind of the data for CanCOVID preg so far, but we are literally getting data every week, and we'll be building this data set and being able to report out periodically with updated information. And the more provinces that come on board and the bigger numbers, obviously, the more robust the information. I just wanted to mention before closing that I'm going to switch hats now. I'm also involved in leading a study that has been funded by the Public Health Agency of Canada, endorsed by the Immunity Task Force, to try and get an understanding of Canadian population seroprevalence of SARS-CoV-2. Utilizing antenatal serum samples. So this is primarily a population level study, but indirectly we will find out the burden of disease in pregnant women that is undiagnosed as well as diagnosed. So we're starting with a current pull of antenatal sera that'll be assayed hopefully in December, where we'll be able to get a snapshot of seroprevalence in most of the provinces in the country. And then we have the opportunity, because of the way antenatal serum samples are handled, in some cases to go back retrospectively and potentially in the future. So, so that's another project, just to briefly mention, that will give us a different type of insight into the burden of disease in Canada for pregnant women. Well, and hopefully as a reflection of the population, which is the primary purpose. So this is the extraordinary team that has been pulled together to try and address these questions. And I have to say that these individuals, for the most part, stepped up long before we had a penny of funding, and we're meeting very regularly starting back in March, April, and have been able to work through the logistics for the most part of getting this data. So I'm going to conclude there. We are very privileged to have Dr. Bonnie Henry as the Provincial Health Officer in BC, and there's this very cute little Science World funding poster where we have the world needs more nerds. So I was kind of fond of that. So thank you for your attention, and I'm more than happy to take questions.
Thank you so much, Deborah. I love that ad. I've seen it on buses. It like warms my heart. We have some questions in the chat box. So we will start with a question from Michelle. She says, Government of Canada's website states that at this time, there's no evidence to suggest that pregnant people are at greater risk, for more serious outcomes related to COVID-19 of having their developing child negatively affected by COVID-19. This seems to contradict the findings of those studies you just highlighted. Are we behind in our recommendations for pregnant women in Canada? Is anything being done to change/update these recommendations?
Sort of yes and yes. So essentially, this data from the United States came out in early November. Prior data from the Living Systematic Review really wasn't showing dramatic increases in adverse outcomes, and most meta-analyses weren't to date. And then we were also in the process of doing our analysis with the Canadian data, and we're, to be honest, a little bit to see the increased rates. So we are in the process of validating our data. We'll be making that public in the very near future. And then once we are able to do that, then we can update the Canadian guidelines and statements.
Great, thank you. And Dora asks, will there be any focus on First Nations data specifically, given the data on COVID and pregnancy in people of color in USA data? Admittedly, a very different type of care, which shows Black, Hispanic, and Hawaiian FN worsened outcomes.
So we have variable ability to pull ethnicity and indigeneity from the different provinces because of the way data is available. I am working right now, they had to cancel their most recent meeting, but there's an Indigenous advisory circle for the Immunity Task Force that I'm going to tap, because it has pretty broad national representation, to get their advice on subset analysis of Indigenous versus non-Indigenous data. And if they are wishing us to do that, then where possible, we will do that. It's obviously a very sensitive issue, but a very important one. And so as the numbers go up, and particularly more in areas with higher Indigenous populations, Manitoba, Nunavut, it would in my opinion, it would be important to do that, but we're looking for advice there.
Thank you. Two questions from Lori. I guess one's a follow-up question. How do the latest findings compare with influenza infection in pregnancy? And also, could you correlate findings with timing of infection in pregnancy and outcomes?
So the first question is that regular influenza has a much lower complication rate and has only a minor uptick in complication between pregnant women and non-pregnant women, although there is a difference. Pandemic H1N1 is looking roughly the same as the data comes out. So pandemic H1N1 we were very concerned about because pregnant women were hit hard. We had a lot of morbidity and mortality globally related to that. And so we're starting to see COVID looking, I would say, more like pandemic H1N1.
Mm.
And then, sorry, the second question.
The second question was, could you correlate findings with timing of infection in pregnancy and outcomes?
We will be able to do that. We have not got that breakdown yet, but we will have it. Yeah.
Okay. I saw a question, this is just a quick one, of will this talk be available afterwards? Yes, but we are waiting for Dr. Money to let us know when this information is publicly available. Once the information is publicly available, we will upload it to CanCOVID's YouTube channel. And finally, from Kathy, will outcomes for the infants and moms be followed?
So at the moment, our protocol, because we wrote it like in April, was to follow to 6 weeks. But as you know, as we're learning and evolving and so on, we will be trying to do longer term follow-up. That we're not currently funded and it's not currently in the protocol, but that is something that I think will be important. And I know our neonatal and pediatric colleagues are particularly interested in the long-term effects of exposed but uninfected infants through this pandemic.
So we have 1 more minute remaining. If there's one more question, we may have time, but if not, this would be a good moment for us to wrap up. All right. Well, thank you so much, Dr. Deborah Money. It was wonderful to have you here today. This talk was so interesting, and we look forward to hearing more about your work.
Pleased to be here. Thanks so much.
Thank you. Bye now.
Bye-bye.